It is not based on any size criteria. If you look oral cavity, oropharynx, hypopharynx, up to T3 it is based on size criteria. But it is based on larynx, it is based on the involvement of the subside. And if you look, the glottic is early stated presentation. And compared to glottic and supraglottic, there is difference in prognosis and outcomes. And in oropharynx, like there is no much difference in outcomes between a soft palate and a tonsil. But that's not the case with larynx. Glottis and supraglottis are entirely different disease. And there is separate staging is the same, but separate treatment. And if you look at NCC, there is separate treatment guidelines for glottic tumor and the supraglottic tumor. And that's different with other sites. If you look into the imaging, why you need an imaging? One, to see the disease, to look the mucosal spread, locoregional treatment, decide the treatment, and for radiotherapy planning, and fourth is to the caudal edge of the cricot cartilage. It extends from the C3 to C6 vertebra. Is divided into supraglottis, glottis, and subglottis. And supraglottis extends from the tip of the epiglottis to the cricoarytenoid joint. If you see a cricot cartilage, arytenoid cartilage, and thyroid cartilage, same in the same CT plane, you say you are at the level of the glottis. Anything below that is subglottis, and this is subglottis. So the biggest area is supraglottis. That's a big area, and this is the largest kingdom in the larynx. And it has epiglottis, aryepiglottic fold. You have the arytenoid cartilage, the false core, and the ventricle. So these are the subsides in supraglottis. So I will try to take you how you have to look in each CT scan at what level you are. That's more important. Second thing is how you stage the disease. This already discussed, so I am not discussing that. This you know as a surgeon, everyone knows this. And the investigation of choice is a thin slice contrast enhanced CT scan is the standard of the investigation of choice for larynx and hypopharynx. And the MRI may be problem solving too. Sometimes it may be a problem making too also. It may be for the specificity of cartilage, the CT is better. The sensitivity is more with MR. If you want to assess the prevertebral muscle involved, prevertebral fascia or muscle involvement, MR may be better. In all the general situations, we generally recommend CT scan as the investigation of choice. Now coming to the epiglottis, how you localize each thing, you need to understand that epiglottis is seen at a higher level. Okay, it's at the level of the floor of the mouth. Okay, so you have the base of tongue here. This is the hyoid bone. This is the thyroid cartilage. So you have the base of tongue here. This is the vallecula, and this is the lingual surface of the epiglottis, and this is the laryngeal surface of the epiglottis. And this between the hyoid and the epiglottis, you have the thyrohyoid membrane, and behind that you have the pre-epiglottic space here. This hypodense area is the pre-epiglottic space. I will discuss that later. And this is the coronal view of the epiglottis. Okay, and this is the hyoid bone, and this is the cartilage. Okay, that's how you make out the epiglottis. And when you have in a lesion like before discuss some CT scans where there is a disease, what all things you should look? One, there is an asymmetric soft tissue prominence or thickening. Always you draw a midline, you compare the right with the left. That's the easy way of learning radiology. And asymmetric soft tissue prominence or thickening, the abnormal contrast enhancement, any definite bulky mass, and always look for the spaces like paraglottic space, pre-epiglottic space that we will discuss later. So if you can see an enhancing lesion in the vallecula. Okay, this is base of tongue, vallecula, and extending into lingual surface epiglottis. So if you say it is a lesion arising in the vallecula, then this is a vallecular lesion extending into the lingual surface epiglottis is T3. But if it is a lesion in the epiglottis, is extending into the vallecula or even the base of tongue, that's only T2. Only when it extends into the extrinsic muscles of the tongue, that becomes a T4 disease. Till then it is a T2 disease. So, and you should always look whether the pre-epiglottic space is intact or not. The pre-epiglottic space involvement is there, it's lower down, that becomes a T3 disease, and there is a high chance for lymphatic spread. And here you can see there is a bulky T1 epiglottis. Now we will discuss the aryepiglottic fold. Okay, so how you look for the aryepiglottic fold. Okay, this is the epiglottis here. The aryepiglottic fold is seen on the lateral aspect. This is the aryepiglottic fold. The aryepiglottic folds comes down, lower down, and it becomes false cord, and it is getting attached to the arytenoid cartilage. Okay, how you look for it? First you make out the epiglottis. This is the piriform fossa. on the right side, this is the piriform fossa on the left side. The area epiglottic fold forms the medial boundary of the the piriform fossa, and it is continuous with the epiglottis. So this is the epiglottis, and this space is the pre-epiglottic space, continuing laterally as the paraglottic fat. So here you have a tumor in the supraglottis. Here you can see a lesion in the area epiglottic fold, epiglottis and the area epiglottic fold. Then if the two sites are involved, then it becomes T2, and you can see the obliteration of the right piriform fossa. Left piriform fossa you can clearly make out. Okay, so this is a right piriform fossa, mild obliteration. This again adds a T2 disease. It's an epiglottis and area epiglottic fold enhancing lesion with an obliteration of the right piriform fossa. Always you look, if you have a lesion like this, two things you need to bear in mind when the lesion is extending into the piriform fossa, like extending into posterior pharyngeal wall, lesion extending anterior in the pre-epiglottic